Wonderful. Thanks, Chelsea. Good afternoon. Thank you for joining us today for MVC's Preoperative Testing Work Group. Chelsea Andrews and I are site engagement coordinators for MVC, and we look forward to facilitating this work group today. Today's preoperative testing work group will feature a presentation by Dr. Nick Berlin, a Reconstructive Microsurgery Fellow at the University of Michigan. Nick completed his integrated plastic surgery residency training at the University of Michigan in 2023. Prior to Michigan, he completed a master's in public health at Yale University, medical degree at the University of Colorado School of Medicine, and the University of Michigan National Clinician Scholars Program. His academic interests leverage expertise in health services and health policy research to improve delivery of high quality, affordable surgical care. Thank you for being here with us today. So before we begin, I just wanted to review a few housekeeping items. First, this session is being recorded. The slides and the recording will be shared with attendees following the work group. Next, we will be monitoring the chat throughout the presentation, so feel free to add questions there. And lastly, your feedback is very important to us. If you could please complete the post work group survey in a link that would be provided in an email following the work group, that will be greatly appreciated. With that, you are welcome to share your presentation, Nick.
Okay. All right, can you see my presentation? Everything look good?
All looks good, thanks.
All right, thank you everyone. My name is Nick. I'm really excited to be here with you all today. I think this is a cool opportunity for me to share some of the work we've been doing here at Michigan and across our state with individuals like yourselves and organizations like MVC. I want to thank Christy for the opportunity to speak today. So I'm going to talk about really low-value pre-op testing. I'm going to talk about some initial lessons in the work that we've been doing over the past couple of years. So I have no financial disclosures. I do want to recommend this resource if you're interested. It's a book that's forthcoming in October, which includes case-based approaches to address common challenges in improving the delivery of surgical care. And there's a specific chapter in this book, which I co-authored with a colleague named Erica Sears, on overuse of preoperative testing for low-risk patients. So this book is coming out in October. If you're interested, go ahead and pick it up. So today I'm going to introduce the concept of low-value care to you. I'm going to review the evidence against routine pre-op testing for low-risk surgery. I'm going to discuss recent studies of low-value pre-op testing in Michigan that we've been conducting, which include the prevalence of low-value testing across our state, variability across and within hospitals, and the association with preoperative consultations before surgery. I'm going to review some of the qualitative work we've been doing at our own institution on barriers to de-implementation of this low-value care, and I'm going to introduce some conceptual models for you to adapt to your own practice settings to affect change. So I doubt anyone on this call needs convincing that healthcare in the United States is expensive. Not only are healthcare expenses increasing dramatically in the US, but they're far outpacing growth in spending for other sectors of the economy. You can see in this figure from McKinsey that growth in the national health expenditures has far exceeded that of the GDP and by wages by more than fourfold since 1960. And not only that, but if we compare spending in the US to other countries, we can see that the US outpaces other wealthy countries with nearly double average per capita spending. And unfortunately, this greater spending does not translate into better health outcomes. As we know, it's generally accepted that the US performs worse in important population health metrics like life expectancy, infant mortality, and unmanaged comorbidities. And while the reasons for this poor value is multifactorial, at least one of the contributors is waste in our healthcare system, which is estimated to contribute more than $750 billion annually with a B. There's a lot written about this so-called waste in our healthcare system, and generally speaking, it's broken down into six buckets. Those are the administrative costs associated with administrative complexity, pricing failures, failure of care delivery, failure of care coordination, fraud and abuse, and the focus of our work on overtreatment, the use of low-value care. which is estimated to contribute approximately $100 billion to annual healthcare spending in the United States. And so how do we define low value care? Well, some would say that value is in the eye of the beholder. And to some extent, that is true, as different stakeholders view value through different lenses and preferences. But in many areas, there is consensus on tests and treatments that are low value. And at its essence, it's not low value care, it's really no value care. These are services that provide little or no benefit to patients. They have the potential to actually cause harm through cascades of secondary procedures and interventions, and also to incur unnecessary costs to the patient or waste resources of our healthcare system. So in the Choosing Wisely campaign, which is this international campaign to identify low value practices by professional societies, one of the main focuses is actually routine preoperative testing before low risk surgery. And there are a lot of different professional societies that have contributed recommendations to this list, including the surgical anesthesia and the pathology of the laboratory testing societies. So here are several of these recommendations. Don't obtain baseline lab studies in patients without a significant systemic disease undergoing low risk surgery. Don't obtain baseline cardiac testing in asymptomatic patients with cardiac disease undergoing low or moderate risk surgery. Don't perform routine pre-op testing before low-risk surgical procedures. Avoid preoperative chest radiography for ambulatory patients with unremarkable history of physical examinations. And then avoid pre-op testing for low-risk surgeries without a clinical indication. This is in part because many of us who provide care to these patients know that these tests produce a wide range of abnormal results, even in healthy individuals. The clinical importance of these results is uncertain. The tests rarely lead to changes in clinical management. The clinical value of these changes in management are often uncertain. Preoperative tests do not accurately predict adverse events. And there's no good evidence to suggest that routine testing in asymptomatic patients provides any benefit. So I'm going to discuss a number of studies that belie a lot of this, a lot of these statements. The first of which is a very large randomized controlled trial of 18,000 patients in 9 centers. This was published in the New England Journal at least 2 decades ago, where they randomized patients to routine testing before cataract surgery, and there was no difference in intra-op or post-op complications. Second study is a Annals of Surgery study in 2012, which is a retrospective cohort study of 74,000 patients who underwent elective hernia repair. 64% of them had a pre-op lab test, and neither the testing itself or an abnormal test result preoperatively was associated with post-operative complications. Another New England Journal of Medicine study in 2015 investigated the kind of variations in testing patterns. They looked at 440,000 Medicare patients who had cataract surgery. More than half of them had at least one preoperative test within 30 days of the surgery that was associated with almost $5 million of increased expenditures. And there was a lot of variation in testing patterns, which is primarily determined by the provider practice patterns. This is another study here of VA patients, 10,000 patients who had low-risk carpal tunnel surgery. 47% had at least one low-value preoperative test within 30 days, substantial variability between the VA hospitals of 0 to 100%. It appeared that older age and female sex were associated with likelihood of testing. This is an interesting study in 2019 where they looked at these things called cascade events, that is tests, treatments, visits, and hospitalizations related to testing for patients who had testing before cataract surgery who didn't have any kind of pre-existing comorbidities like heart disease. It was 110,000 patients. About 1 in 10 had a preoperative EKG, and over more than 1 in 10 of those patients had a cascade event, which accounted for about $500 per beneficiary and $35 million across the Medicare beneficiaries in this population. Finally, this is not just limited to the United States. This is an international phenomenon. In Canada, a study of 1.5 million patients who had low-risk surgical procedures at over 130 hospitals. 1 in 3 had an EKG or chest radiography. Variation between hospitals was between 3 and 90%. In older patients, and those referred for a preoperative consultation were more likely to have testing. So again, the tests produce a wide range of abnormal results. The clinical importance is uncertain. They rarely lead to changes in management. The clinical value of these changes in management are often uncertain. They do not predict adverse events, And there's no good evidence to suggest that routine testing in asymptomatic patients provides any benefit. So our team here at Michigan has been focused on strategies to reduce pre-op testing before low-risk ambulatory surgery. And to do this, we've partnered with two organizations. The first organization is called MProve. This is an organization here in Ann Arbor. And the second organization is one that you're all very familiar with, MVC. I'm going to first describe MProve, and then we'll discuss some of the work that we've been doing together. So MProve, which stands for the Michigan Program on Value Enhancement, is an interdisciplinary program at Michigan that bridges the gap between the quality department and IHPI, which is one of the HSR think tanks at Michigan. And MProve brings expertise in research design, policy evaluation, quantitative and qualitative methodologies, and intervention design to collaborate with organizations within our organization to bridge the gap between research and clinical practice. That is implementation science, creating innovation and quality improvement, working with partners across the health system, and focusing on improving the appropriateness of care. And you all know the Michigan Value Collaborative. This is the second organization that we've been partnering with, which is a statewide effort to reduce. This is a statewide effort to reduce low-value pre-op testing. It's a Blue Cross Blue Shield funded collaborative with more than 100 hospitals and 40 physician organizations across the state. And MVC is a really unique partner in this effort because you're all uniquely positioned and resourced to leverage data analytics and near real-time administrative data for more than 100 hospitals to look at utilization outcomes and spending. And you work with the individual quality collaboratives like the Michigan Surgical Quality Collaborative to provide data support to a variety of interventions to improve quality and safety. And so beyond the limited clinical benefit of low-value testing, one of the main reasons why Blue Cross Blue Shield is interested in reducing low-value testing is obvious. It's because it's expensive. Nationwide, low-value pre-op testing accounts for nearly $18 billion of spending in the United States annually. And in the state of Michigan, MVC has estimated that pre-op testing for patients undergoing just these three procedures alone, that is elective hernia, groin hernia repair, lumpectomy, and lap cholecystectomy, accounts for $3.7 million in expenditures annually. So here's a number of studies that we've been doing here at Michigan and across our state. The first one was published in 2021, looking at patterns and determinants of low-value preoperative testing. We first asked, well, what is the extent of low-value testing across our own state? And so to answer this question, we identified patients who underwent three common ambulatory surgical procedures, that is lumpectomies, laparoscopic inguinal hernia repairs or groin hernia repairs, and laparoscopic cholecystectomies. We used the MVC data and assessed the extent to which these patients underwent testing within 30 days of the surgical procedure. That's 30 days before the procedure. And the tests we looked at were these lab studies, EKGs, cardiac testing, pulmonary function tests, urinalyses, and chest radiography. And importantly, we excluded testing that was done in the emergency setting or an inpatient setting in that 30-day window because that testing would actually be indicated potentially. So consistent with other studies on this topic, we found that low-value testing was really common across Michigan. And among more than 40,000 patients who underwent one of these three procedures at the 60 hospitals, at least 1 in 2 patients had at least one test, and 1 in 3 patients had 2 or more tests. And so using data from MVC, we demonstrated that testing rates varied widely between hospitals. You guys are used to seeing these caterpillar plots. Each dot represents a hospital from MVC, and the colors are the different procedures here: lumpectomy, cholecystectomy, and a hernia repair. The y-axis is the rate of any testing within 30 days of preoperatively of the surgery. And you can see that for each of these procedures, the rate of pre-op testing varied between 20 to 80%. And that's even after adjusting for patient comorbidities and various inconsistencies in the data collection. We saw this graph and we had one of those light bulb moments where you realize there's an enormous opportunity to improve the way we deliver care in the state. And what about our own institution? Are we at Michigan some kind of positive deviant in the rate of low-value pre-op testing? Unfortunately not. Here we are, or hopefully that's where we were, with relatively high risk-adjusted testing rates compared to other hospitals across the state. And this was actually consistent for the 3 procedures individually. Then we asked the question, what about within hospitals? So this is a slightly different caterpillar plot. And if If you look at the gray line, we organized hospital, the gray dots, we organized hospitals according to their average testing rates for these 3 procedures. That's the gray dot. And then we looked at the individual testing rates for the surgical procedures within each hospital. And so you'll see for the hospital I've highlighted here, you can see that the testing rate for lumpectomy was nearly 90% at this hospital, while the rate of testing for patients undergoing a lap chole or a lap hernia repair was 20 to 40%. This is pretty strong evidence to this to suggest that there are factors within the hospitals that play out in affecting the delivery of postoperative or preoperative care, that you can imagine why this would take place because of different service lines, specialty specific cultures, perioperative protocols, et cetera. So the conclusions of this study were that testing is really common. There's wide inter and intra-hospital variations. To reduce testing, you may want to target specific hospitals in addition to individual practitioners. And pre-op H&Ps, is I didn't really show this, but pre-op H&Ps, these consultations before surgery, may be a driver of testing. A second study we did was we wanted to look more and investigate their association with low value testing. We used the same sample, and we showed that patients who had a preoperative consultations, that is, these patients are referred for an evaluation like a history and physical examination before a low risk surgery. Patients who had that beforehand were more likely to have testing in nearly every single category. And you can see that here. That played out in our adjusted models as well. And so these pre-op H&Ps are also common, even among younger patients with no comorbidities. These consultations are associated with low value testing, and they may be a potential lever or target for de-implementation. So next, we worked within our own institution with this quantitative data. We then partnered with MProve, that organization I discussed earlier. And we conducted a qualitative investigation into the facilitators and barriers to de-implementation of low value testing for these procedures. And here are some of the themes that emerged from interviews with more than 7 surgical subspecialties about the preoperative process. A potential facilitators to de-implementation was that routine testing was frequently viewed as low value. One individual described it as unnecessary or redundant or just checking a box. It has a low likelihood of influencing care, which we know. One individual said that with lower risk patients, the times that those go through testing would actually change anything or result in a change in or postponement of surgery or needing to further optimize the patient would be relatively rare. And another potential facilitator to de-implementation we identified was that there are incentives to reduce pre-op testing, which are important, potentially to improve the efficiency of the preoperative process. I believe that it was a surgeon or an anesthesiologist that said, I don't think it should be one that size fits all. We shouldn't have to jump through so many hoops in order to make it to the OR. But there are barriers that we identified as well. And there was 2 themes that emerged. One that was a concern for safety. We all know that complications can occur regardless of the pre-op evaluation. It's better to be safe and just have everyone go through the testing. Another individual said, I think one of the big barriers would be just to making sure that everyone knows that the policy is what it is. Our group here in Michigan did a focused ethnographic study where they did semi-structured interviews and direct observations with a number of individuals between that work at different H&P clinics as well as an outpatient surgery center, did a thematic analysis and identified several themes in this study that I think are important as you consider implementing any kind of change practice at your own institution. These themes were shared values that those individuals who are providing care in the preoperative period want to prioritize patient safety and evidence-based medicine, but that there are gaps in knowledge, meaning that there's discrepancies related to the existing guidelines that exist in the literature and what exists at your own institution. And there's an obvious communication breakdown. This is a multidisciplinary stage of care, and so testing is often ordered to meet the perceived needs or the perceived expectations of other providers. So our team with MProve has taken both the qualitative and these quantitative findings and is currently designing interventions to reduce testing rates at our institution with the ultimate goal of improving the efficiency of the preoperative process. So to do this, we're mapping intervention strategies with barriers identified in the qualitative investigation. So here's an example of mapping these strategies with the barriers. For instance, to address differing perspectives among stakeholders unequal awareness of guidelines, and differences in cultural norms. We're developing and disseminating consensus guidelines and doing provider education. And other interventions that are currently being considered or actually happening include audit feedback, clinical decision support tools that are embedded within the EMR systems, and finally, financial incentives locally and in coordination with Blue Cross Blue Shield. So leading up to our work on pre-op testing for lumpectomy, lap chole and lap inguinal hernia repair, MPROVE successfully worked with the Department of Ophthalmology to reduce the testing rate prior to cataract surgery. And through an intervention that included provider education and preoperative risk stratification, testing rates plummeted in 2018 without a substantial increase in cancellation rates or perioperative complications. And so for those of you on this call who actively engage in QI efforts within your institution, this is a nice article in BMJ that I wanted to highlight for you on this topic, authored by one of the PIs here at the University of Michigan, Dr. Leslie Dossett. So in this article, Dr. Dawson and colleagues discussed an approach to risk stratification that may inform an effort to improve appropriateness of pre-op testing within your institution. And so the quadrant here is really what we've been discussing today. That's the one where patients are considered low risk and the surgery is considered minor or intermediate risk elective surgery. That is skin and soft tissue excision, breast biopsies, ophthalmologic surgery like cataract surgery, lap inguinal hernia repair, knee arthroscopy, or lap cholecystectomy. That's where routine testing is not indicated. Though it's important to know that it is reasonable to do comorbidity-specific pre-op testing for high-risk patients undergoing these same surgeries. And of course, for patients undergoing major elective surgeries, procedure-specific testing or a comprehensive evaluation by anesthesia or a preoperative H&P clinic they are reasonable as well. And so if you wanted to say reduce rates of EKG testing before cataract surgery, this would be an example of a PDSA model that might help you conceptualize a strategy to address this problem. In the plan phase, you'd review data on the EKG overuse with key stakeholders to obtain support and resources for change. You'd form a stakeholder team responsible for implementing change. You'd review and update preoperative guidelines to reflect evidence-based guidelines. You'd educate staff and trainees on these new guidelines, and you review or eliminate order sets or automated processes contributing to unnecessary testing. In the study phase, you might monitor the impact of the intervention, identify barriers to new protocols and or clinicians, monitor for unintended consequences or workarounds. And then in the act phase, you'd continue to enforce the new guidelines to staff and trainees and provide feedback on success in ongoing areas for improvement. And so now we'll plug for MVC. Again, MVC has this capacity and resources to create anonymous risk-adjusted benchmarking for every participating hospital for rates of pre-op testing and trends over time. And so clinical champions at the partnering hospitals then receive this information and can decide whether to intervene on it. Here's one example of a report that was sent to a hospital, which shows the breakdown of testing rates by surgery type, testing type with risk-adjusted comparisons to similar hospitals. And MVC is also doing a statewide value coalition campaign to improve awareness about this issue, share publications on this topic and campaign goals, and upcoming events related to testing. Here's the 2021 progress report that was sent to participating hospitals. And so in summary, I've shared our initial experience with de-implementation of low-value pre-op testing from within and across hospitals in Michigan. Some of the lessons we've learned are to focus on low-hanging fruit. First, to conserve your resources and affect change quickly. This can lead to early success and momentum for future work in this area. To leverage both qualitative and quantitative methodologies to get a sense of the problem and the facilitators and barriers to de-implementation of this practice within your institution. And then both within and across Michigan, having a robust data management strategy has been essentially. And finally, recent reviews and evidence for de-implementation support the design of multi-level interventions at a patient, provider, and a systems level. So there are a lot of people that have been involved in this work. This is not an exhaustive list here, but I do want to give a big thank you to the two PIs that have been leading a lot of this work, Dr. Leslie Dossett and Dr. Hari Nathan. And I'm happy to take any questions that you have during the Q&A.
Thanks so much, Nick. What questions do we have? feel free to put them in the chat or also unmute yourself as well.
Hi, my name is Monica, and I was wondering, Blue Cross Blue Shield has their neighborhoods and their medical homes, and the medical homes are usually the PCPs who provide a lot of the clearances for these patients. Is this information also being sent out through Blue Cross to these entities to help facilitate this? Because many times the surgeons will send their patients to the primary doctor to get a clearance, and the doctors will order all the tests to clear the patient, maybe not having all this new information.
Christy, do you know the answer to that?
I'm not sure of the answer to that. It definitely is a good question. Do you have more knowledge?
So yeah, I'll chime in. I doubt that that's being disseminated to these medical homes. I mean, we're kind of at this point, it's a patchwork of services. And so the same issues that we identified in our qualitative work here at Michigan is probably exists across a larger system of care, specifically when you refer an individual patient back to a medical home to get their preoperative clearance. The communication between the surgeon or the anesthesia team at the hospital may or may not be great. And so the understanding between those groups about what tests are indicated maybe could be improved. Let's just put it that way. So I don't think that these types of guidelines are being disseminated widely, at least by Blue Cross Blue Shield. But a lot of the primary care physicians are aware of this problem, and it is kind of the bane of their existence, to be honest.
Thanks, Nick.
There's a comment and a question in the chat from Heather. Heather, are you up to asking that to the group?
Sure, I wasn't sure if I was going to be able to unmute or not.
No worries.
A lot of our preoperative testing is being guided by our anesthesia group rather than the surgeon, and they're a lot. I found they're more difficult to work with in changing practice than our surgery group. So I'm just wondering if anybody's had any luck working with anesthesia in mitigating these testing orders or changing their PAT scripting and protocols or anything along those lines.
Does anyone have any insight for Heather?
I don't have any insight on that specifically. I think they're a really key stakeholder in this process. It's funny. Sometimes I'll show up to the pre-op area and there'll be an EKG that was ordered by the H&P clinic that will be done on the morning of. And I'm always wondering who's following up on the EKG, who's liable for the results of this EKG, particularly for a low risk surgery. But in general, the preoperative clinic, at least here at Michigan, and I believe other places too, anesthesia plays a really important role in coordinating the care and overseeing the care delivered in those clinics. And so they're a really important stakeholder. And so breaking through to that group is a really important step.
Hi, Heather. I found that what was very helpful in our facility was actually I had a sit-down meeting with our chief of anesthesia and our general surgeons, who are generally the people doing the surgeries in this preoperative testing pilot. And I found that I had more luck with the doctors and the anesthesiologists being able to talk to each other and kind of work out where they were having difficulties and not being on the same page. Right now, I'm still in the process. I just finished our baseline data, so I'm not really sure how well it's working. I have been checking. Our pre-op staff told me that things are going more smoothly, but I don't have the data yet to back it up. But hopefully that is something that worked for us.
Thank you.
Any other questions for the group? Are there any other groups that you all are working with in addition to, the anesthesia teams and the surgical teams to address preoperative testing procedures and standard operation practices? Or any success stories that anyone could share with others to supplement Nick's wonderful experiences?
Hi, it's Audra again. So one of the things that I found in getting ready for kind of our kickoff in March with the meetings with the surgeons and the anesthesiologists, I was looking through our company policies and what our preoperative testing parameters were at the time. And one of the things I ran into, and it's still actually an issue, is that we are now trying to be more corporatized. So we're running into corporate policies instead of site-based policies. And our corporate policy directly contradicts the preoperative testing guidelines that have been laid out in this group. So I ended up getting involved with some of our corporate people, that there's a corporate policy team, and there's a whole lot of red tape with that, but they actually have taken that policy and are trying to get it more in line with what the recommendations are, but that takes time. So definitely brought in a couple more players.
Yeah, that's a really great point. That's something that we've been trying to learn more about our members within the MVC membership, specifically, is how systems and hospitals and physician organizations are partnering together, and that top-down versus bottom-up approaches to practices. So thanks for sharing that experience, Audra. You're at McLaren, correct?
Yes,
Okay.
McLaren Lapeer.
Lapeer, yeah. Thank you for sharing that. Yeah, I agree with Jana.
Welcome.
There's more and more system level activity these days.
Yeah, it kind of seems like the deeper you dig, the deeper you have to dig, kind of thing.
Yeah.
Any other questions or comments from anyone? It was a very detailed presentation, Nick, so I think everyone's looking forward to having those slides for review after and sending them to their respective team members.
Yeah, and I'm also happy to be a resource too if anyone wants to reach out to me directly.
Wonderful.
Well, I appreciate all of your presentation, Nick. Just to reiterate what Christy said, and Pam, appreciate you sharing those with the MSQC members. If anyone has any questions, we can certainly CC you on the email if you'd prefer. So everyone's got your email address quickly accessible, easily accessible in the post work group send out.
Sounds great.
Pass it over to Christy and she can pull up her closing slides.
Awesome, that sounds great. So let me pull up my upcoming event slides just to review some things we have going on in August as well as September. I'm going to share my screen really quickly. Can everyone see that okay?
Looks great.
Okay, wonderful. So thank you again, Nick, for presenting today. Really great information. We're looking forward to kind of seeing the future of preoperative testing. We will look forward to sending those materials to the work group registrants following this meeting. So I did just want to review some upcoming events. On August 9th from 10 a.m. to 12 p.m. we will have a virtual rural health meeting. That is going to feature presenters Dr. Ross Ramsey from Sure Health, as well as Mariah Hesse, who is the Michigan Critical Access Hospital Quality Network president. So we're really looking forward to that meeting. That meeting also will include an unblinded data review session for MVC rural hospitals. So we hope to see you there. We also have a health equity work group coming up at the end of August on August 24th from 11 to 12 o'clock p.m. That will feature Janae Tyus from the Community Health Access Program of Greater Flint Health Coalition. And lastly, our first work group in September will be a sepsis-focused work group, and that will be on September 14th from 2 o'clock to 3 o'clock p.m. and feature Tammy Garcia with the Quality Department at Michigan Medicine. So with all of that, I would like to remind everyone again, the slides and recording will be shared following the work group. If you have any questions about the work group, please reach out to us. Thank you for being here today and attending this work group. Going forward, if you know of anyone who'd be interested in speaking at an upcoming work group, or if you yourself would like to speak, please contact the MVC engagement team. Once again, thank you for your support of MVC, and we look forward to seeing you at future work groups. Have a great day.
Thank you all. Have a great rest of your afternoon.
Thanks, Nick.